Imagine stepping into the barn, the familiar scent of hay and horse all around you, but then tryst. Then you spot it. Your horse, normally bright-eyed, alert, is squinting, tearing up,
Yeah.
and one eye just looks, well, wrong? Maybe clouded, but swollen perhaps. And then it feels like just hours later, it gets worse, much worse. That awful sinking feeling. That's the dread, knowing how fast things can go south with a horse's eye.
It can happen incredibly quickly.
Welcome to the deep dive. Today, we're really plunging into a condition that kind of embodies that fear. Equine ulcerative keratomycosis, or as most people know it, a fungal eye infection in horses.
Right.
And this isn't just, a minor thing. It's severe, it's progressive, it poses a huge threat to vision, sometimes even the whole eye.
It really does.
So our mission here is to cut through some of that complexity. We'll explore what this is, why it's actually pretty common in horses, how vets diagnose it, the treatments which sound intense, and maybe most importantly, how you listening can help with prevention and spotting it early.
And just to give you a sense of scale right away, fungal keratitis. It's seen way more often in horses compared to, say, dogs or cats. It's definitely not some rare disease.
Really?
Yes, some reports, especially from teaching hospitals, show it can account for anywhere from like 24% up to a staggering 86% of their equine eye cases.
Wow, 24 to 86%? That's a massive chunk of eye problems.
It is.
It really highlights why owners need to know about this.
Yeah.
So when we talk about a fungal eye infection, is it just one thing? Or does it show up in different ways?
That's a really important distinction, actually, and it's critical because it changes how you approach treatment right from the start. Broadly, you see two main presentations.
Okay.
First, there's stromal ulcerative keratitis. Think of that as an open wound on the cornea, actual tissue loss, an ulcer.
Okay, like an open sore.
Exactly. Then there's the fungal stromal abscess. Now here, the cornea isn't openly ulcerated on the surface. The infection, the sort of cellular gunk, is trapped deeper inside the corneal layers. The surface might even look fairly intact.
So one's an open wound, the other's like something growing underneath. That difference sounds huge for treatment.
It is.
If it's trapped under the surface, I guess getting medication to the fungus is way harder.
Exactly right. That intact surface layer, the epithelium in an abscess, it really blocks topical medications from getting in properly. So often you need different ways to deliver the drugs, or sometimes you have to consider surgery earlier just to get those therapeutic levels where they need to be.
Okay, let's unpack this a bit. Why horses? Why are they so prone to these fungal things in the first place? Are these fungi just kind of floating around everywhere?
Well, what's kind of surprising is that, yes, the fungi that cause these infections are pretty much everywhere. They're ubiquitous, found all over the horse's environment: hay, grass, shavings, even dust. And what's maybe even more surprising, these organisms are actually normal inhabitants on the surface of a healthy horse's eye.
Wait, they're supposed to be there.
In small numbers, yeah. They're part of the normal microflora. So finding them isn't necessarily the problem. The issue arises when the horse's natural defenses get compromised or the eye's environment changes. That's when they switch from being, harmless residents to actual pathogens.
Okay.
The main culprits we usually see are filamentous types like Aspergillus and Fusarium.
So they're like opportunistic invaders just waiting for an opening. What kind of things give them that chance? Environmental factors.
Oh, absolutely. Environment plays a massive role. We definitely see the highest number of cases in warm, humid places. Think southeastern United States.
Right.
In other areas, like maybe the northeast U.S., you see a real seasonality. It peaks in summer and fall when it's hot and humid.
Oh.
And it's not just the heat and humidity. Dust is a big one. And especially high wind speeds. Wind can kick up spores from hay or plants and increase the concentration in the air.
Makes sense. More spores flying around.
Exactly. Plus, those same things, dust, wind, bits of plants, can directly irritate or even slightly injure the cornea, making it easier for the fungi to get a foothold.
Okay, so beyond the environment, what about the horse itself? Is there something about horses that makes them particularly vulnerable?
Yeah, there definitely is. It's a combination of their anatomy and, well, their behavior.
How so?
Well, first, their eyes are huge, right? And they stick out. That just inherently makes them more likely to get bumped, scratched, poked.
True, they're quite prominent.
Very. Then there's the fact that horses tend to rub their eyes on their legs, on fences, stall doors.
Oh yeah, you see that somewhere.
Right. And even a tiny scratch, something you might not even notice, can be a direct doorway for these fungi. And then, to make things worse, these fungi seem to have a particular liking for a specific deep layer in the cornea called Descemet's membrane.
This is membrane.
Okay.
So the cornea has layers.
Yeah, think of it like an onion. Descemet's is one of the deepest, strongest layers. But these fungi, they like to head deep. They have a tropism for it, meaning they're kind of drawn to it.
So they don't just stay on the surface.
Often not. They push deeper, which makes these infections much, much harder to treat effectively. And that's why, what seems like a minor scratch can suddenly blow up into a really severe fungal infection, especially because they aim deep.
That's a really critical point. Even a small scratch needs checking out right away.
Yeah.
Okay, but what about things we do? Veterinary care. Can our attempts to help sometimes, backfire?
Yes, unfortunately. That's a really crucial area to understand. Iatrogenic factors, we call them. Meaning things caused inadvertently by medical treatment. For example, using topical antibiotics for a long time, or especially topical corticosteroids for other eye issues.
How does that cause a problem?
Well, prolonged antibiotics can wipe out the normal protective bacteria on the eye's surface, which can allow fungi to overgrow. And corticosteroids, while great for reducing inflammation, also suppress the eye's local immune response.
So they lower the defenses.
Exactly. They can create this permissive environment where fungi, which might normally be kept in check, can suddenly multiply and invade. This really underscores why vets need to be suspicious of a fungal infection if a corneal ulcer isn't healing like it should with standard antibiotic treatment.
Okay.
It's a red flag to maybe stop the steroids if they're being used and definitely get some fungal tests done.
So if you've been treating an eye for, say, a couple of days and it's just not getting better,
yeah,
it's a big warning sign.
Huge.
Let's talk more about that then, the signs, how these infections actually look and progress. What are the early things an owner might see?
The early signs are often, pretty nonspecific for just eye pain. You'll see significant discomfort. The horse will be squinting a lot. We call that blepharospasm.
Blepharospasm, okay.
Lots of tearing, that's epiphora. Redness around the eye, maybe the eyelids look swollen. And the cornea itself, the clear part, might start to look cloudy or hazy. Sometimes people call it a blue eye because of the corneal edema, the swelling.
And amidst all those general sore eye signs, what's the real red flag that should make someone think, uh-oh, maybe this is fungal?
The single most important clue, really, is an ulcer that just doesn't show signs of healing within about 2 to 3 days, even with initial treatment like antibiotics and pain meds.
2 to 3 days. That's quick.
It is. That lack of response, or if it actually looks worse in that time frame, should strongly raise suspicion for fungus. We call that a complicated ulcer, and fungus is high on the list of possibilities.
Okay. And if it is fungal and starts progressing, what does it actually look like? You hear terms thrown around. I think I read about a cake frosting appearance.
Yeah, that's a classic description. The appearance can really vary, though. You might see small, superficial ulcers or these distinct white or yellowish plaques on the cornea.
Plaques, okay.
That cake frosting look is pretty characteristic. It's usually an ulcerated spot with this kind of uniform white or yellow base and border. It looks dry, almost fuzzy, often due to dead tissue and fungal elements.
Like someone literally frosted the eye.
Sort of, yeah.
Yeah.
Now, stromal abscesses, remember those deeper ones? They look different. Because the surface might heal over, trapping the infection inside, they often appear as this smooth, yellowish haze, or even a distinct lump within the clear cornea.
Right, under the surface kind.
Exactly. And in really severe cases, you might see a descemetocele. That's when the ulcer has eaten through almost all the corneal layers, right down to that deep Descemet's membrane we talked about.
Oh, wow.
And that membrane starts to bulge outwards like a tiny clear bubble because of the pressure inside the eye. Very dangerous, very close to rupturing.
That sounds terrifying.
It is. And then you have melting ulcers. That's when the cornea is undergoing rapid liquefaction, basically dissolving due to aggressive enzymes produced by the fungi or the body's own inflammatory response. That can lead to a full rupture, a perforation, incredibly quickly.
Melting is a good description then. Sounds incredibly aggressive. Are there specific signs that scream, this is really bad, act now?
Yes. One particularly concerning sign is when a distinct furrow develops around one of those fungal plaques.
A furrow, like a trench.
Exactly. A deep groove or excavation digs into the corneal tissue around the main lesion. And this can happen fast, sometimes within 24 to 48 hours.
That quickly.
Yeah. It signals really aggressive tissue destruction, what we call stromal degradation. It's a bad sign associated with a poorer prognosis, and it means you need immediate aggressive intervention. You have to try and stop that melting process.
Right.
Because ultimately, the worst outcome is corneal perforation, an actual hole through the eye. And that is significantly linked to losing vision or even losing the eye itself.
What about inflammation inside the eye? Does that usually happen too?
Oh, absolutely. Inflammation of the middle layer of the eye uveitis is pretty much a consistent finding with these fungal corneal ulcers.
Like an internal fire spreading.
That's a good way to think about it. It shows up as a constricted pupil. The black center of the eye gets really small. That's meiosis. And you might see the fluid inside the front chamber of the eye look cloudy or hazy, almost smoky. That's protein leaking in, called aqueous flare, or sometimes even pus, which is hypopyon. And this uveitis causes a lot of pain.
So it's not just the ulcer, it's the whole eye reacting.
Exactly. And if that uveitis isn't controlled, it can cause serious irreversible problems on its own. Things like adhesions where the iris sticks to the lens synechia, or glaucoma, increased eye pressure, or cataracts, clouding of the lens, all of which can wreck vision. So managing that internal inflammation, the uveitis, is just as critical as fighting the fungus itself if you want to save sight and keep the horse comfortable.
Okay, this is clearly a formidable foe. So once a vet suspects fungus, how do they actually nail the diagnosis? What tools do they use?
Well, the cornerstone always is a really thorough ophthalmic exam.
Just looking closely.
Looking very closely, often with magnification. But it usually requires sedation, maybe even nerve blocks around the eye.
Why is that? Just because it hurts?
Partly pain, yes, but also just the horse's natural tendency to flinch or move its head. You need the horse comfortable and still to get a really good look at subtle lesions and, importantly, to collect samples properly. A rushed or compromised exam means you could miss things.
Makes sense. Okay, beyond just looking, what about those diagnostic stains? I know fluorescein is common for ulcers. Anything else helpful here?
Fluorescein is definitely standard procedure. It sticks to areas where the corneal surface, the epithelium, is broken, highlighting ulcers.
Right.
But for fungal cases, rose bengal stain can be particularly useful too.
Rose bengal, how's that different?
It tends to stain devitalized cells and mucus. So it can pick up really subtle, tiny surface defects, little microerosions or problems in the tear film's protective mucin layer that might stain really weakly or maybe not at all with fluorescein. Oh. And this is important because sometimes fungi get in through those very subtle defects. So just because fluorescein is negative doesn't automatically rule out fungal keratitis. We might also check the tear film breakup time, TFBUT, which tells us about tear film stability, another factor in corneal health.
Okay, so stains give clues, but to know for sure it's fungus, you need lab work, right? What's the best way to do that?
Right.
What are the downsides?
Right. Lab confirmation is ideal. For potentially rapid preliminary results, you can do cytology. That involves gently scraping the corneal lesion and smearing the sample on a slide to look for fungal elements like hyphae under the microscope.
Okay, quick look.
Can be quick, yeah, but the big limitation is sensitivity. It doesn't always pick up the fungus, especially if the infection is deep or if you don't get a great sample. So a negative cytology doesn't mean no fungus.
Right, not definitive.
Not definitive. For the most reliable diagnosis, and importantly for figuring out which antifungal drugs might work best, that susceptibility testing fungal culture is often considered the gold standard.
Culture sounds good, but...
But the major drawback is time. Fungi can be slow growers. It can take, 10 to 14 days, sometimes longer, to get results back from the lab.
2 weeks, when the eye is potentially melting.
Exactly. That's a huge delay when you're dealing with an aggressive infection. So you absolutely cannot wait for culture results to start treatment. You have to start therapy empirically, meaning based on your strong clinical suspicion right away. The culture results, when they eventually come, can help you fine-tune the treatment later if needed.
That's a long wait. Are there any faster ways to get a more definitive answer?
Yes, thankfully. PCR polymerase chain reaction is a molecular technique. It looks for fungal DNA directly in the sample.
DNA testing.
Right. It's generally much faster than culture, often giving results in a day or two, and it's highly sensitive. It can even detect fungi that are difficult to grow in a lab.
Sounds perfect. Any catches?
The main caveat is interpretation. Because, as we said, fungi are kind of everywhere, you might sometimes get a positive PCR result just from environmental contamination or from non-viable fungal bits. So you have to correlate the PCR result carefully with the clinical signs. Is the horse showing active disease?
Gotcha. Context is key.
Exactly. And then there's histopathology, looking at a tissue biopsy under the microscope. That's very definitive, but it's invasive, usually reserved for cases that go to surgery anyway, or maybe if all other tests are coming back inconclusive.
Okay. And what about advanced imaging? Can you actually see the fungus inside the eye in more detail?
Yes, advanced imaging can give us incredible insights, especially for those deeper or more complex cases. The slit lamp biomicroscope is sort of the workhorse. It's a powerful microscope that lets us see the eye's fine structures, assess the depth of the lesion, how it's growing.
Right, the standard tool?
But then you have things like laser scanning confocal microscopy, LSCM. This is amazing. It provides real-time, super high-resolution images of the fungal structures within the living cornea without needing a biopsy.
Wow, like looking right into the tissue.
Pretty much. And anterior segment optical coherence tomography, ASOCT. That uses light waves to create cross-sectional images, like a map of the corneal layers. It's fantastic for seeing exactly how deep a lesion goes or mapping out an abscess. These technologies really help guide treatment decisions, especially when deciding if surgery is needed.
That is incredible technology.
Yeah.
Really gives you a detailed picture. All right, so you've got the diagnosis, you know what you're fighting. What's the battle plan? Sounds like it needs to be pretty aggressive.
It absolutely has to be. Effective management needs a multimodal approach. You're usually combining aggressive medical therapy and very often surgical intervention as well.
Okay, let's start with the medical side. What are the main drugs?
Yeah.
What's the biggest hurdle there?
Topical antifungals are the absolute cornerstone, the foundation of treatment.
Okay.
We have a few main classes. There are polyenes, like natamycin. That one's actually FDA approved for fungal keratitis in humans and horses. It's effective, but its big limitation is poor penetration, especially if the corneal surface is intact.
So good for surface stuff.
Good for surface stuff, yeah. Then there are azoles, like voriconazole. Voriconazole is often preferred, especially for deeper infections or abscesses, because it generally has a broader spectrum of activity. And it's been shown to penetrate the cornea much better than natamycin.
It gets deeper. That's key.
Very key. But the biggest challenge, honestly, isn't just which drug, it's how often you give it. You need really frequent topical application. We're talking every 2 to 4 hours initially, around the
Every 2 hours, 247. That sounds exhausting.
It is. For the owner, for the horse, you need to maintain high enough drug concentrations in the cornea to kill the fungus, and the eye's natural tear film washes things away quickly. That's why subpalpebral lavage systems, SPLs, are so incredibly valuable.
SPLs, what are those?
It's basically a thin tube that a vet places under the horse's eyelid, usually stitched or glued in place with the end coming out near the pole or mane. This allows you to attach a syringe and deliver medication directly onto the eye surface frequently, or even set up a continuous infusion without having to physically pry the painful eye open every couple of hours. Huge help, especially for fractious or very painful horses.
That sounds like a lifesaver, literally. Okay, so antifungals are key. What else is needed to support the eye and the horse?
Right. It's rarely just the antifungal. Concomitant therapies are essential. We almost always use topical broad-spectrum antibiotics, too.
Why antibiotics if it's a fungus?
Because secondary bacterial infections are really common. Maybe in about a third of cases, you get bacteria jumping into, so you cover your bases.
Okay.
Then systemic NSAIDs, non-steroidal anti-inflammatory drugs like flunixin, meglumine, banamine are crucial. They manage the pain, which is significant, and they help control that internal inflammation, the uveitis.
Right, got to fight that fire too.
Absolutely. And we use topical atropine. It's a drop that dilates the pupil. This helps relieve pain from pupil spasm and, importantly, prevents the iris from sticking down to the lens, those synechia we mentioned. We use atropine cautiously, though, because it can potentially slow down gut motility, so you monitor for signs of colic.
Good point. Anything else for specific situations, like those melting ulcers?
Yes. For those rapidly progressing melting ulcers where the cornea is actively dissolving, you need anti-collagenase agents. These drugs inhibit the enzymes that are breaking down the corneal collagen.
Okay, stop the melting.
Exactly. Common options include autologous serum, making eye drops from the horse's own blood serum, or drugs like EDTA or N-acetylcysteine. These are critical to try and stabilize the cornea.
Wow, using the horse's own blood.
Yeah. The serum contains natural antiproteases, And then you can't forget basic supportive care. A well-fitted fly mask is important, keeps flies away, reduces light sensitivity, maybe helps keep medication in a bit longer, protects from bumps.
Simple but effective.
Definitely. And making sure the horse gets some gentle exercise if possible helps prevent systemic issues like colic or stocking up from just standing in a stall. Good nutrition, of course, supports healing overall.
It's a whole horse approach, really.
It has to be.
So given how aggressive this can be, surgery seems like it would come up pretty often. When do you typically decide medical treatment isn't enough?
Surgery becomes a strong consideration or even a necessity in several situations. If the ulcer is really deep, say, deeper than about half the corneal thickness, or if it's just not responding well to aggressive medical therapy after a reasonable period, maybe about a week or so.
Okay.
That furrow sign we talked about, that aggressive trenching, that's often an indication for surgery sooner rather than later. And of course, if the eye perforates or is about to perforate, surgery is usually needed immediately to save the eye.
Makes sense. What kind of surgical techniques are used?
There are several options depending on the situation. Sometimes just debridement, carefully removing the dead tissue and fungal plaques from the surface, or a superficial keratectomy, which is shaving off the diseased layer, can help. This removes the bulk of the infection and can allow medications to penetrate better.
Cleaning it up, essentially.
Right. For deeper defects or to provide structural support, a conjunctival graft is very common.
Conjunctival graft. What's that involve?
The vet takes a small flap of the conjunctiva, that pink tissue lining the inside of the eyelids and covering the white of the eye, and carefully sutures it over the corneal defect.
Wow.
This brings an immediate blood supply directly to the ulcer, which delivers healing factors and immune cells, and it acts like a biological patch, providing tectonic support to prevent rupture.
Like patching a tire, almost.
Kind of, yeah. A living patch. Amniotic membrane transplantation is another option, using processed equine amniotic membrane from the placenta as a graft. It has anti-inflammatory and anti-scarring properties and acts as a scaffold for healing, helping to preserve the globe's structure.
Amazing what can be done. And for the absolute worst cases, what about actual corneal transplant?
Yes, for the most severe cases where a large portion of the cornea is diseased or maybe even perforated, corneal transplantation is an option. This involves removing the diseased corneal tissue and replacing it with healthy donor corneal tissue.
Like an organ transplant for the eye.
Essentially, yes. It can be a full-thickness transplant, penetrating keratoplasty, or a partial-thickness one, lamellar keratoplasty. And what's really encouraging is that the success rates, particularly for penetrating keratoplasty and preserving vision in horses with these severe fungal infections, have become quite high in recent years. Some studies report success rates up to like 94.7%.
94%. That's incredible, considering how bad things must be to need a transplant.
It really shows how effective these aggressive surgical interventions can be when combined with good medical management.
So pulling it all together.
Oh,
What's the realistic outcome for a horse diagnosed with fungal keratomycosis? Is saving vision likely, or is blindness a common result?
well, the prognosis is generally considered guarded to poor if it's not caught early and treated aggressively. But with prompt, aggressive treatment, vision retention rates vary quite a bit depending on the study and the severity. Maybe around 50 to 75% with medical treatment alone in some reports. But when you combine medical and surgical therapy for the more severe cases, success rates for saving vision can jump up to over 90%.
That's a big difference surgery can make.
Huge. But even with the best efforts, blindness in the affected eye can still happen. Maybe around 25% of cases, unfortunately, might end up blind in that eye despite treatment.
Still a significant risk then. What specific things tend to lead to a worse outcome?
The key negative factors are definitely the depth of the infection when it's first diagnosed deeper is worse. The presence of that furrow sign we discussed, that's a really bad prognostic indicator. Actual corneal perforation, obviously. Uncontrolled uveitis, the internal inflammation, is also a big problem. And just a general lack of response to initial therapy within those first critical days.
Right, if it's not turning around quickly.
Exactly. And even if you successfully treat the infection and save the eye and maybe even vision, corneal scarring is a very common long-term consequence.
A permanent mark.
Often, yes, it can range from just a faint haze that doesn't really affect sight to a dense white scar, a leucoma that can significantly impair vision depending on its size and location.
Okay. And beyond the eye itself, you mentioned systemic risks during treatment. What are the main worries there?
Yeah, the treatment process itself, especially involving hospitalization and intensive therapy, it can take a toll on the horse systemically. Colic is probably the most commonly reported significant complication.
Colic from eye treatment.
It seems linked to the stress of hospitalization, maybe changes in feed or routine, pain, potentially some effect from medications like atropine or NSAIDs. Reports vary, but maybe 10% to over 21% of hospitalized cases experience colic, and the risk might even be higher right after general anesthesia if surgery was done.
That's a serious secondary risk.
It is. Other potential issues could be things like diarrhea, changes in blood work, electrolyte imbalances, or even laminitis in rare cases, usually associated with prolonged stress, pain, or confinement. And then, of course, you can have ongoing ocular complications too, like persistent uveitis even after the infection clears, recurrence of the fungal infection later on, or problems related to the SPL catheter like infection or irritation, or issues with graft healing if surgery was performed.
It sounds like a long and challenging road for both horse and owner, which really brings us back to prevention. If these fungi are everywhere and horses are prone, what can owners actually do to minimize the risk?
That's the million-dollar question, isn't it? Since you can't eliminate the fungi and horses are just horses, prevention really focuses on two main things: minimizing the chance of corneal injury in the first place and maintaining a healthy eye surface.
Okay, so how do you minimize injury risk?
Good barn hygiene is a start. Regular stall cleaning helps reduce overall dust and potential contaminants. Making sure hay isn't excessively dusty or moldy is important, maybe soaking or steaming hay for sensitive horses. Good ventilation in the barn helps reduce airborne particles.
Common sense stuff, but important.
Definitely. Then, think about the horse's turnout environment, reducing exposure to irritants like sharp grasses, seed heads, or overly dusty arenas. Using protective gear like well-fitted fly masks can be a huge help.
Fly masks as physical barriers.
Exactly. They can protect against flies, dust, UV light, and minor bumps or pokes. For some horses in really high-risk environments, specialized protective goggles are even an option. And just doing regular safety checks of pastures and stalls, removing stray nails, broken fence boards, low-hanging branches, anything sharp they could potentially run into.
Makes sense. Basic safety checks.
Right. Preventing that initial trauma is key.
And for keeping the eye surface healthy and catching things early, what's the owner's role there?
The owner's role is absolutely critical. Daily eye checks are essential.
Every single day.
Every single day. You need to actually look at both eyes closely, even if it means lifting up the fly mask for a quick inspection. Check for any subtle signs more tearing than usual, slight squinting, any redness, any cloudiness, or obviously any visible scratch or injury, no matter how tiny it seems.
And if you see something, even something small,
call the vet immediately. This is probably the most crucial piece of advice. Any eye injury, no matter how minor it appears, warrants prompt veterinary attention. Don't take a wait-and-see approach.
Because it can escalate so fast.
Exactly. As we've discussed, what looks like a simple scratch today could be a raging fungal infection in just a couple of days if those opportunistic fungi get involved. Early diagnosis and appropriate treatment make a world of difference in the outcome.
Okay.
Also, making sure any underlying eye conditions, like maybe dry eye or eyelid problems that could compromise the cornea, are properly managed. And for some horses, maybe just occasional gentle rinsing with sterile saline can help keep the surface clean, but that's something to discuss with your vet.
So it really comes down to vigilance and quick action.
Absolutely. It's this holistic approach. Minimizing environmental risks, protecting the eye, daily monitoring by the owner, and immediate veterinary intervention for any injury. That's the best strategy we have against this really devastating disease.
Well, today we've certainly taken a deep dive into equine ulcerative keratomycosis. We've tried to unravel some of its complexities. We've talked about these fungi that are just everywhere, the horse's own unique vulnerabilities, their anatomy, their behaviors that make them susceptible, and how incredibly fast this disease can progress.
Like frighteningly fast sometimes.
We've explored the diagnostic challenges vets face, needing that high index of suspicion and using those advanced tools, and the treatment intensive doesn't quite cover it. Multimodal, aggressive medical therapy, often combined with pretty advanced surgery.
That requires a huge commitment.
Yeah. I think the core takeaway is pretty clear. Timeliness and a really comprehensive, aggressive approach are absolutely vital for having the best chance of saving that horse's vision, maybe even the eye itself.
Couldn't agree more. Early and aggressive are the key words.
But maybe let's end with a thought for you, our listener, to mull over. Given how truly ubiquitous these fungi are, just part of the horse's normal world, and how inherently prone horses seem to be to eye trauma, is the real deep dive Maybe less about battling the infection once it grabs hold, and more about our constant vigilance as caregivers, acting as that first and maybe most vital line of defense for our horse's incredibly delicate vision.
That's a really powerful way to frame it. Vigilance is everything.